Everyone, welcome to another episode of our career assessments. Today we have Bree, and she is a acute care nurse practitioner. She's joining us. She's going to talk all about her job, how to get into it, and all of the wonderful, beautiful things. In this series, we're just going through a bunch of different healthcare jobs, talking about what they are, how you get into them, all things related to that. We've done a few in the past. I will leave them in the description. And today, I'm so excited. We have an Acute Care NP. This is totally not my world. I am a family nurse practitioner, and I'm grateful people like you exist because I cannot. So would you like to introduce yourself, Bree, and tell us a little bit about you?
Yeah, I would love to. I got to tell you, though, I have known Nurse Liz for a while now, back before I was even getting on social media. She took the time to reach out to me when I asked her some questions, and I'm like in a little bit of a celebrity shock state here right now. And same to you with the FNP thing. Like everybody I know is an acute care nurse practitioner. So trying to find FNP friends to give me advice is hard. You're it.
Yeah. There we go. That's fine.
Niche, right? We have our lane that we get into, and that's where we tend to stay.
Exactly.
That's cool. So as you said, my name is Bree. I'm an adult Gero acute care nurse practitioner. I've been out of practice. Well, see, I was a nurse for 16 years and then finally decided to go back to school. Yep, long time. Took me a long time to make that decision. And then basically what happened was my 4-year-old went to pre-K and I was like, well, what do I do now? So I decided it was time to go back to school, kind of later in life. But that is a whole nother story. But so I graduated 5 years ago, and I've been working in the ICU basically ever since as a critical care nurse practitioner.
Awesome. What kind of ICU is it? Is it in a specialty, or is it just kind of like the ICU?
Yeah, so it's interesting. I've had a couple of jobs as an NP in the ICU, and it's different everywhere you go. I work in a mixed setting. So we are a critical care service, and we cover multiple different ICUs, which I really love. I get to go to mostly in a medical ICU. We do a heck of a lot of COVID. We have a dedicated COVID ICU right now, which is its own battle. I go to a CCU and I go to CVICU. So it's nice because I get a little change up. I do a whole lot of heart failure one week, and next week I'm back to medical, and then somebody's got to draw the short straw and go to COVID. So I take a little bit of that for a while and then I get back. So I'm constantly like using my brain, and I don't feel like I get pigeonholed into one critical care specialty. So I really, really love where I work currently for that.
That's amazing. Is that pretty typical? Like that you would float between all of those, or is that like make you a unicorn?
It varies based on where you go. I mean, I work at a level 2 training institution, so it's a bigger organization. I do find that at those kind of places, they tend to be kind of more segmented, actually. It's, you'll have a neuro team, you'll have a surgical trauma team, you'll have a cardiovascular team. So that's typically how it goes. And then when you go to a smaller community hospital where it's just one ICU, you're going to get everything that comes in there. So it just depends on where you go and what environment you're working in as to what you're going to be exposed to and what you're going to see.
Yeah. So probably a lot I feel like with a lot of NP things, it's kind of just like, well, it depends on where you work. But that's amazing that you jump to all of them, because I feel like I did peds cardiac for a long time, and I left med surg because med surg was just so much. I was like, I want to niche down as a nurse. Yeah. So that's like amazing that you're like, I can just do all of them. It's fine. It's perfect.
Well, but there's a lot I can't do. I mean, do not put me in an urgent care. Do not ask me to do anything neurologically. I mean, I know my thing, and then I stay away from what I don't know.
Neuro. Yeah, neuro. I'm like, ooh, can you see? Okay. Yeah, you're going to need to go somewhere else.
What are the
I don't really have any idea. Exactly. I'm like, make your face do this. And then I'm like, I don't even know what to do if it doesn't work. Please help.
You have to go way back that training on Old Olympus.
Exactly. I'm like, I have no help here. So what was your nursing background? You said you worked for 16 years before. What did that kind of look like? Did you work on like all ICU units? What did that kind of look?
No, I was a serial job hopper. I have had a gazillion jobs. I actually, one of the things that I do in the business so I started out in social media making YouTube content for nurses and NPs and mentoring and that kind of thing. And it segued into a business. And one of the things that I do is mock interviews. People are always asking me about my interview experience. I'm like, dude, I have been on so many interviews, both as a nurse and as an NP. I can tell you about all of them. But I'm just that kind of person. Awesome. I sort of always felt like if I tapped out my knowledge base and my experience and I was at the top of my comfort level, I just I just felt stagnant. So I always changed. So I started out not in the med surg route. Actually, I graduated nursing school in 2000. And at that time, Trauma Life in the ER was the big reality show. And I was like, ooh, I want to go and be a trauma nurse. So I managed to pull some strings, and I got a job in a level 1 ER. That was the best of times and worst of times. And it was fun, a lot of fun, but it's like just the stuff you see in the ER, particularly level 1 inner city, you just stand on the wall like, is this real life?
Yeah.
I was 20 years old too, so there was that, but it was fun. And then I did ER for 6 years. Most of it I traveled, so I do have some experience traveling. And then I thought, well, I need to learn ICU, so I went to work in a surgical trauma ICU. And then I did home health care for a while because my kids were little and that was flexible for them. And then I did palliative care for a little while. And then I went back to medical ICU. And then I was like, all right, it's time to go back to school. So I bounced around.
What a cool background, though. I feel like you've seen all of it too. So you can sympathize with like all the different aspects of like what's going to happen to this patient when we send them home, and then they're going to need home health, and like, let's get palliative care involved. Like, you're like the whole package human. That's awesome.
Well, I mean, honestly, everything I ever did built upon it itself. And I actually just made a TikTok on this yesterday because someone was asking me specifically which of my experiences as a nurse has helped me the most as an NP. And I'm like, every single bit of it, every single job has helped me. Like, I mean, and here's specific examples. Like, when I'm admitting a patient to the hospital, I know from my home health care days that they're probably bouncing back from the last discharge because there were limitations on the prescriptions they could fill, or the CPAP machine didn't arrive on time. And I know when I take that history, what specific questions to ask. You know, people don't think home health care, it totally does. Same thing with ER. I mean, I learned how to diagnose in the ER, how to hone in on like a mystery patient about what could be wrong and what the pertinents are and how to make the diagnosis. And in the ICU, how to deal with badness. When badness happens, you know, here's what you do. Here's comfort level with the ventilator. Here's comfort level with pressors. And then like the things they don't teach you in school, you know, like I's and O's in the hospital, they're never right because all it takes is one nurse missing a bag of bank and you're off by 500. But that's something that you learn by working as a nurse. You don't learn that through school. These residents, I work alongside a lot of residents. And so a lot of the pattern recognition that is just inherent when you have a background as a nurse, they lack it because they have no experience doing that at the bedside. So every single thing you do as a nurse contributes to your profession as a nurse practitioner, all of it.
I love that. And I exactly say the exact same thing when people are like, I'm going to kind of do this, like, but I don't want to ruin it. Like whatever. I'm like, you're going to learn something, like, even if you're not expecting it, like literally, or even if it's just communication, like you said, and like learning how to like talk about difficult things, like that's a huge skill that takes forever. Like, and you're going to need to know how to do it. Is there one job that you would say, like, if someone was watching this and they want to be an acute care NP, they're in the beginning of their career, what is there one that helped you like the most in terms of being a acute care NP? Or
I mean, ICU for sure. I think most programs, well, I don't know, schools are changing a lot right now, but a lot of schools request that you have ICU experience. I think that you should, if you want to do the acute thing. Now, it doesn't mean you have to go into ICU, but you need to have some familiarity with what a patient looks like when they're decompensating and needs the ICU. And, you know, if you're going to be an acute care NP and work in a hospital setting, that's what you need to know. So I think working in an ICU is the most beneficial. I went to school with a guy who did ER. He had no training in ICU, and he went to work for a trauma service, and he's done just fine. So I think ER, ICU are probably the top two, I would say, that help you in recognizing problems and patterns and managing acutely decompensating people, which is what acute care is all about.
For sure. I think it's really helpful, like you said, to take care of have a background in taking care of people that are one step sicker than kind of what you're used to. That way you can be like I do that. It's so helpful for me outpatient because I've dealt with them med-surg. It was like a med-surg / intermediate unit. And I'm like, I know what you look like when you need to be admitted and you're not there, or like, oh, you are, like, just let's keep going. And it's difficult. If you haven't ever seen sick, you're like, oh, I don't really no. So I could totally see what you mean by like, it's, if you only have ever worked in med-surg, I mean, you would kind of know, but it would definitely be helpful to have some kind of ICU. And I feel like the ER is its own type of like critical care in its own weird like world.
It is its own world, just like the OR.
It is its
own places.
Yes. I used to think I wanted to work in the ER, and then I did a rotation. I was like, no. I am not.
I felt the same way about OB and peds. Both of them, I was like, no.
Oh no. OB, I was like, oh no. There's not enough patients here. Yeah, no. Not enough. Not at all. But the peds got to me. I was like, we'll do this.
I bet I want to do peds, but I think the special person. I think a lot of people underestimate how hard peds is, because you gotta be able to really turn it off when things aren't going well. And I couldn't. I would bring that kind of stuff home with me. So hats off to all you peds people. Like,
I am eternally grateful that I really wanted to go to the PICU, and I didn't get a job interview there until I had already gotten my cardiac job. And the nice thing about cardiac was so many kids did well, and it was very surgical. So it was like, let me fix you, let me send you. It wasn't like, horrible TBI type things. So like that was kind of how I could do it, because I don't know how people do like the PICU. I'm like, especially once you have kids, I'd be like, I would no. Oh my gosh. No. Yeah. So you work in the ICU. What other jobs can you kind of have as an acute care NP? Can you be like a hospitalist? Can you ever work in a clinic? Like stuff like that?
This is, okay. I'm so glad you asked this question, because this is really complicated, right? And when I was trying to go back to school, I really suffered from paralysis by analysis. This whole like, what do I want to do? And there's a lot of crossover between FNP and acute care. And this is why I think we keep coming back to these two. There are a lot of specialties that you can go into as a nurse practitioner, but these are the two that cross over the most. So you hear this debate all the time. And I hear from people when they come in for consultations, like, which route should I take? Okay, here's the thing. If you think about an acute care nurse practitioner as someone who only works in the hospital, and an FNP as someone who only works in the clinic, you're missing out on a lot of things. And that's why it gets confusing, because that is assigning them a career based on a setting. And we are not defined on who we can treat by our setting. We're defined by our role and our population. So if you try and think about things a little differently, like as an acute care NP, the role of patients that I am taking care of are the people who are acutely decompensating, versus like the people you're taking care of. Yeah, like you are promoting wellness, you're doing disease education, you are helping keep people who may have chronic diseases well at home. So the people who are kind of doing okay with a little bit of problems, that's who you're treating. You're also treating people across the lifespan. So in acute care, it's very different. I'm doing the opposite. I'm treating people for a short period of time. I don't have lifelong interactions with them. I definitely cannot treat people across the lifespan, because I'm adult Gero, so adult and up. I can't do mommies or babies or children. And I take care of people who are either acutely sick or acutely decompensating from a chronic problem. So whatever setting that happens in, I can do that. I can do that in the hospital as an ICU nurse or NP. I can do that as any kind of the specialties. So ID, neuro, ortho, surgery, there's renal. There are, basically any of the organ systems that have a specialty, you can work as an NP in the hospital. But in addition to that, I could also work in clinic, but only in those specialty roles. So if I'm treating someone, say, that came into the hospital for a fractured leg, had surgery, and then is doing follow-up care in a clinic, at an ortho surgery clinic, I can see that patient both in clinic and in the hospital. But I can't prescribe that patient hypertensive medications, and I can't treat their diabetes, and I can't do disease education outside of the role that I'm treating them for. So if you think about it like that, that's why you see people in all these different roles. You see acute care nurse practitioners primarily in the hospital, but sometimes in clinic, and sometimes they will work in clinic for a while and then round in the hospital for a while. That is the beauty of acute care, is you can kind of go back and forth a little bit on that. And the same with your position. I mean, you primarily see FNPs in clinic, but there are FNPs in the hospital, urgent care, fast track, ideal situation for an FNP. They can treat people across the lifespan. I cannot. So that's why you get the confusion about what you can and can't do.
Oh yeah.
This all the time.
It's such a mess.
All the time.
Especially people were like, I want to work in the ER. I'm like, oh boy. Okay.
Well, that's two different, like, what part of the ER? Do you want to do the acutely dying in the ER? Do you
Exactly.
want to do the kind you're walking into?
Yep. Yep. I'm like, this is
It's
so nuanced. But I
confusing.
love the way you framed that with like, are you acutely decompensating, or are you like, what stage are you in? Like, is it kind of a short-term thing or a long-term thing?
Yeah.
I think that's
Yeah.
a really nice, easier way to like think about it versus, like you said, setting and all the other stuff.
Yeah.
So you said you can do adults. So it's adult Gero acute care. There is a pediatric one. And that's like pediatric acute care. What age do you cut off?
16 and up I can do.
Okay.
That's what I'm certified for. Anything below that. And I also cannot take care of mommies. So I have little to no training in OB. So now this gets really a little bit hairy sometimes, because the place where I practice, we have a very large OBGYN population. There's a big maternity unit. And occasionally, it's rare, but occasionally you get the mommy with HELP syndrome, or that's thrown a clot and they end up in the ICU, and there's not an ICU for them. So it borders on my discomfort level, but I'm always working hand in hand with a physician, and the physician is essentially the one assuming that liability, and I'm just treating basically the mommy. But I'll just leave it at that. Sometimes you're going to run into situations where you're like, ooh, I wasn't taught this.
Yeah. What do you mind talking about those? Because I think I've gotten that question a lot before in a different interview, was like, what is the biggest scope of practice thing that makes you go like, ooh? Like for me, it's a lot of like either the pregnancy thing where I'm like, technically I can, or like going into psych meds, or like, how far do I want to dip my toes into this before I stop? Is there something in that you do that's kind of like, this is the fringe and it makes me feel oof?
Yeah. So all of those, I mean, I never encounter peds or babies, but mommies make me very nervous. I rely on my OB physicians a lot for that. And also, it is rare, but there are times when we discharge patients from the ICU. That always makes me just a little bit uncomfortable, because I'm like, how do I write a prescription? I don't know. I mean, I'm used to writing orders. Like I put an order in, no problem. I don't even have a DEA number. I mean, I just write an order for narcotics all the time. I don't know how to write a prescription. Like, and how many do they need? Do they need enough to get them through for 2 days? Like, I don't,
Oh my gosh. Yeah. That's fascinating that you don't have a DEA number. Yeah. I'm like, oh, well, you don't have the pharmacy calling you like all the time. It's like, hey, it's Fred from CVS. You messed up again. You're like, Fred.
Yeah. Did you really mean to do that? No, I didn't.
They're like, hi, Liz. You're like, hi, Fred. Such fun relationships.
Love those pharmacists.
Oh my goodness. I would mind. I had like great ones, and then ones where you were like, you know what I mean. Like, you know what I meant.
Yeah. Help me help you, please.
Exactly. Okay. So that's helpful. I think it's good to always like kind of look at that and see like, what are kind of like the fringe weird things where you're like, not really like totally sure.
You're going to run across that stuff. That's where it's good to have collaboration with your physician. You know, typically in a hospital, you're always going to be in collaboration with a physician. So you just always need to go to them and say, look, I'm not certified for this.
Yeah. So can you walk us through kind of like what your team what a team usually looks like, what your role on it is? I guess kind of just like what a day in your life sort of looks like when you come to work, your work schedule, all of that good stuff.
So I love my work schedule. So I work like nurses. We work 3/12s, and then I have 4 days off. They're almost never 12-hour days. They're actually closer to 13, and they're they can be, and typically are very high energy, high stress, fast paced. So it's exhausting 3 days, but then I have 4 days off where I'm not on call, where I'm, I never carry notes.
No call.
My notes are done. I may stay late, but my notes are always done. So when I'm off, I'm off. So I love the work-life balance that I have with this schedule, which isn't always the case for inpatient NPs. I mean, I know a lot who do 7 on, 7 off. I know some in some of the specialties who do 5 days a week. So it just varies based on, are you in private practice? Are you employed by a physician's group? It's all over the place. I've thought about going to a 5-day week thing, and sometimes it's appealing, and the other times I'm like, no, it's 5 whole days.
Yeah, it's a lot of days. Day. Yeah, and coming off of 12s, you're like, what? Like, when do you do your life? Like,
Yeah, exactly.
What is happening?
So it's and then the daily flow is it's fast paced. So I come in, I do sign. We are a very big team, very very big team. So we will come in as a group and we'll run through the whole list, which can take a very long period of time, depending on how many patients we have on our census at that time. But we run through the whole service so that we're all vaguely familiar with the patients, and then we break up into groups. So it'll be myself, a physician, and a team of residents, and we will be responsible for one unit, and then they'll divvy up the workload. I'll get my assignment. I go and pre-round on all my people and check them out and talk to the nurses and kind of look up all their information as much as I can and get like a sketch idea of a plan, and hope I have enough time to get all that done before rounds start. And then we do rounds. And again, I work in an academic institution, and so rounds can be a long period of time. So I always have an NP student with me. So I usually bring my student and my notes, and we start writing our notes as we work down through rounds.
Oh, that's a good idea. Yeah.
Yeah. So usually it works out because the residents will have to present their patients. It takes a while, and it's not always in the same geographic region. So I can see one, and then we can do rounds and do another one, and you just work it out. What throws a wrench in things are when you get patients who are crashing that you have to stop and go take care of, which happens all the time, or a new consult or admit, and you have to stop and go do that. So it is very much a rolling plan. It's not always the same. I like that, though. I like that kind of ever-changing atmosphere and the buzz and the excitement. I kind of get a little that, so I like it.
Yeah.
So we do rounds, and then we'll do notes, which is the biggest chunk of my day, notes all afternoon, and lines, procedures, new admits and new consults usually roll in around 4 or 5, and then we just roll in to sign out that night. It's nonstop.
And it sounds like it. I'm so grateful for people like you, because that's all I like just predictable. I'm like, okay, everything is going as boring, as wonderful as possible.
That's okay. That's okay. We all have our niche, right?
Yes. And I'm very happy that people like you exist who are like, yes. I'm very sorry that you're very sick right now, but let's go. How long or how many patients do you usually have that you are kind of responsible for? Or is it more of just varies. Everyone has everybody?
Yeah, that varies with our census load. It can range anywhere from 4 or 5 patients to 9 or 10, which is a lot. It can sometimes be more than that. We've had some pretty hairy situations with COVID where it's been more than that. And you just do the best you can. Just a bit. But in an ICU setting, I mean, it's weird because you can have 3 patients and they are the sickest ones in the hospital, and you are slammed all day long with those 3. Or you can have 9 fairly unchanging patients you don't have a lot to do on, not a lot of family drama, that you're sitting around twiddling your thumbs. So you never know what to predict in ICU. You just never know. Often the patient who's acutely decompensating that you're slow coding, you can be in that room for hours of the day, and that sucks up your entire day. It's always changing.
It totally depends. Yeah. And do you have a lot of autonomy, you feel like, with your own patients? You can obviously go to the physicians that are there and get their input, but do you feel like you get to do your thing when they are your patients?
I totally do. And I have I've had a couple of jobs as an NP. I've done some moonlighting elsewhere and other places, and I've been at this job since the beginning, and I've seen it done differently in different places. And I'll just say this. When I started, I remember talking to my professor and saying, well, I want to work somewhere where it's a good work environment. She says, you're going to want somewhere with tons of autonomy, where they'll let you do all the things. I'm like, I'm scared to death. I'm not good. She said, trust me, in a year, you will want that. And she was totally right. Because once you get competent and then confident, you feel very stifled when you don't work somewhere that allows you to practice to at least to a decent amount of your scope. It doesn't even have to be the full
for sure.
Extent. If you at least are able to contribute in a way other than just writing notes and being a scribe, it is so much more fulfilling. And I definitely have that where I'm at. The physician who started this program was very pro APP. And so everybody they've hired on board, it is like a unicorn job. It's amazing. They invest in us, they value us, they teach us, and then they just kind of let us do our thing. So I have a lot of autonomy. if I have a patient who's acutely crashing, I'll do all the procedures, I'll intubate, I'll do the lines, and then I'll follow up and let the family know things aren't looking good. Sometimes you run into other groups or other places where physicians won't let you do any of that. So you're just sort of the workhorse. And while that can be okay when you're new, when you become competent, you don't feel like you're doing as much as you could.
Oh yeah. And it's a total, I remember thinking that as a new grad too. I was like, I just want someone to hold my hand the whole time. But then you're right. Like at that year, once you start getting comfortable, you're like, I actually have a style of how I like to do things. And like, I want to do it. Like, I kind of like want to be in charge of it. So I totally get, that's awesome. So it sounds like you've had mostly good experiences. I mean, at your job. And then obviously there's probably going to be like teams that are, less than enthusiastic about working with nurse practitioners, and it's usually pretty easy to tell.
That exists everywhere. And the longer I'm on TikTok, the more I realize they all live on TikTok anonymously, and there are plenty of physicians who are not pro APP, and that's okay.
Yeah, and on Reddit, they have their whole. I'm like, wow, you have like there's some ego struggle. Like,
it is not a team collaboration for many people.
Yeah, it is. Yeah. Is there anything that you like can't do in your role in terms of like that a physician would have to do that you? All right, friends. So this ended up being a way longer interview than I had originally planned because we just had a lot to talk about and went on different awesome tangents that I wasn't expecting, which is always the best. It's like nice when stuff comes up organically. However, I wanted to break this up into 2. That way it would be a little bit easier to watch in case you are interested in learning more and you don't have like a ton of time right now. So I am going to make a part 2 to this. And in the part 2, we're going to be covering a lot of like NP school, going into more of just details of what this kind of looks like day to day, talking about charting, all of that kind of good stuff. So make sure to stick around for part 2. That will be coming out in a day or 2. Subscribe if you enjoy content like this. If you would be interested in sharing like your healthcare career, it doesn't have to be nursing, it doesn't have to be NP, make sure to email me. I'll leave my email right here and let me know. And you can be the next guest on our career assessment as we learn about all sorts of different healthcare careers, because it's really hard to shadow and no one will let you in anywhere. So it's hard to know what to do. But she gives a ton of really great advice in terms of like, if you would like to end up in this sort of career, in the second half of this interview, and I don't want you to miss it. So make sure to stay tuned. Thank you so much, Bree, for working with us on here. I am going to leave she has a ton of awesome resources for acute care NPs. I'm going to leave her website, her Instagram, her TikTok, all linked down below. That way you can go and check them out. They're well worth it. She has a YouTube channel. She's just like the acute care version of me. So it's great. I'm very glad I discovered her and have found a new friend. So thanks for watching today, and we will see you in part 2.